Thank you, Cheryl. All right, everyone. Good evening. It's 6 o'clock. I think we can get started. Welcome to this session of G-Echo Gastroenterological Teaching Sessions. This is hosted by the Gastro Foundation in association with Project ECHO, the University of New Mexico. And these sessions, for those who don't know, is run every second Monday at this time at 6 o'clock, primarily aimed at medical fellows in GIT. However, the forum is open to anyone who would like to join. We will run the session. The chat will be open for you to place questions. We'll come to those questions at the end of the meeting. Alternatively, at the end, we can also open the forum if you want to raise hands and ask your questions verbally. That's also fine. All right. So I think without sort of further ado, I'm really glad to welcome Muaz Moosa. He's a fellow with us in Cape Town. And tonight we're going to discuss acute cholecystitis and cholangitis. Muaz has put together a great presentation, and I think you can all look forward to hearing it. So over to you, Muaz. So Muaz, I'm not sure if perhaps your mic is still on or off, sorry. We saw your slides a moment ago. I think you just want to try and share with us again. Okay, that's great. We can see that if you should be able to switch. Yeah, that's great.
All right. Are you able to hear me now?
Yeah, and we can hear you nicely now. Great.
All right.
Thank you.
Okay, thank you very much. Today we are going to talk about acute biliary infections. I'm going to talk about acute cholangitis and then subsequently acute cholecystitis. As we all know that acute cholangitis is a very serious, it's a potentially fatal medical emergency, hence requires urgent recognition and urgent treatment in terms of antibiotics and intervention. It is a severe inflammatory condition of the bile duct caused by blockage of the bile duct with subsequent raised pressure within the bile duct and bacterial growth. This was first described by Charcot as symptoms of hepatic fever in 1877, but subsequently has evolved drastically in terms of the diagnosis. We are all very, very familiar with the Charcot's trial, which I will be discussing later on. Looking at the pathogenesis of acute cholangitis, the primary cause is actually, as I mentioned earlier, the bacterial infection in the setting of biliary obstruction. So these are two prerequisites for development of acute cholangitis. Most often it is due to the ascending infection from the duodenum. However, it can rarely occur via hematogenous spread from the portal vein. So normally there are protective mechanisms in us which prevents this kind of infection, like mechanical barrier like sphincter of Oddi, which actually prevents duodenal reflux. And the other factor is actually continuous flow of bile as well as the bacteriostatic properties of bile salts, which maintains the sterility of the bile. Apart from that, there is a secretory IgA as well as biliary mucus, which prevents bacterial adherence and subsequently colonization by the bacteria. However, in some times, because of there's a role of foreign body, like in cases of stones or stents, which acts as a medium for bacterial colonization. In studies that have looked at the sterility of the bile in patients, those who had without obstruction, the bile is usually sterile. However, if there is a presence of gallstone, up to 70% of the bile is positive for bacteria, which is more common in cases where the bile duct if the stone is in bile duct compared to being present in the gallbladder. Looking at the microbiology, more than 90% of the cases of acute cholangitis has positive cultures in the bile. The organisms are usually mixed growth, mostly the colonic organisms by means of gram-negative. E. coli accounts for most of the it accounts for about 25 to 50%, followed by Klebsiella and Enterobacter. The gram-positive organisms like Enterococcus species accounts for around 10 to 20%. There are also anaerobes, but usually it's under-detected because of the routine cultures. However, this is often seen in recurrent as well as post-surgical cases. This diagram actually summarizes the pathophysiology of acute cholangitis, which I mentioned earlier on, which two hallmarks are necessary, as I mentioned, with regard to biliary obstruction. It can be by means of stone, stricture, or PSC, or various other conditions as well. So which leads to the elevated pressure because of the decreased prevention of a bile flow, which increases the pressure within the bile duct, and subsequently the ascending bacterial contamination of the bile duct leads to the infection. There may be, because of the increased pressure, there may be reflux of the bile into the venous and lymphatic system. Sometimes, apart from the ascending contamination from the duodenum, some rare occasions, hematogenous contamination of the biliary tract can also occur. So, as I mentioned earlier on, the most famous thing about acute cholangitis is the Charcot's trial, which has been described since 1877, which describes presence of fever, abdominal pain, and jaundice. However, this is only seen in around 50 to 75% of the cases. With regard to the frequency of symptoms, fever and abdominal pain accounts for 80% of the cases, and jaundice is only seen in 60 to 70% of the cases. Subsequently, in 1959, Raynaud described the acute severe suppurative cholangitis, which described later on Raynaud's pentad. Apart from the Charcot's trial, he added hypertension and change in mental status, which later became as Raynaud's pentad. Having said that, these various symptoms might not be typically seen especially in the elderly population, and then those who are immunocompromised, especially on glucocorticosteroids. So these patients, the only symptom may be hypotension. And sometimes this patient also may present with the complications related to the bacteremia, like hepatic abscess, or they may present with sepsis or multi-organ dysfunction and shock. So we have a better understanding, or better, more sensitive means for diagnosing the disease, given its increased high rate of mortality. So international consensus group met in Tokyo in 2007 and initially developed initial criteria. But having said that, even that criteria was also relatively low compared to what we are using currently. But over the years, it has improved in terms of diagnostic accuracy with current Tokyo guideline. The latest one in Tokyo 2018 guideline has over 90% of sensitivity for diagnosing acute cholangitis. The various criteria that has been used in the Tokyo guideline is for acute cholangitis include looking at the three parameters, mainly looking at systemic inflammation, cholestasis, and imaging features. If there are looking at systemic inflammation, which looks for the presence of fever or shaking chills. Fever is defined as more than 38 degrees Celsius or more. If there is a laboratory evidence of inflammatory process like raised white blood cell count or elevated CRP, or if there are biochemical features of jaundice like bilirubin of more than 2 grams per deciliter, or if there are biochemical features of abnormal LFT with regard to raised alkaline phosphatase, GGT or ALT, AST, if upper limit of more than 1.5 times upper limit, or if there are imaging features of biliary dilatation or evidence of etiology on the imaging. So when you look at these three parameters, either one item if there's one item positive in A, B, and C, then it is definitive diagnosis. However, in cases, if it is only one item in A with either one item in B and C, then it is considered as a suspected diagnosis. So as I mentioned earlier on, the diagnostic performance has improved, given that this is a condition with a high mortality. The diagnostic accuracy should be high, and the sensitivity of whatever we are criteria that we are using is over 90%. However, having said that, there are some limitations in current diagnostic criteria with regard to very mild cases and atypical cases. And then the next important thing is classifying these patients into severity. If there's the Tokyo guideline categorizes them into mild, moderate, and severe based on the involvement of the organ function as well as predictive factors. So looking closely with the severe acute cholangitis criteria, it is considered as severe if it is associated with any onset of dysfunction in any one of the following organ system, either in terms of cardiovascular dysfunction by means of hypertension requiring dopamine of more than 5 microgram per kg per minute, or if there is any dose of norepinephrine use, or if there is a neurological dysfunction by means of decreased contrast level, or if there's any respiratory dysfunction like acute lung injury or renal dysfunction by means of raised creatinine of more than 2 gram or oliguria or hepatic dysfunction, or if there is any evidence of hematological involvement like dysfunction like a decreased platelet less than 100,000. If acute cholangitis is considered to be moderate, if there is any two of the following criteria by means of raised white blood cell count of more than 12 or less than 4,000, or if the fever is more than 39, or the age of the patient is more than equal to 75, or if there is evidence of hyperbilirubinemia of more than 5 milligram per deciliter, or if there is evidence of hypoalbuminemia. If it is considered to be mild if it does not fall into any of the categories if it does not fall into moderate or severe. So in terms of imaging that we use, ultrasound is recommended to be the first line because it has high specificity, and CT is the other modality that can identify the cause and then complications as well. Also helps in differentiating or looking at other potential other similar presentations as well. And MRCP has a higher sensitivity for stones as well as malignancy as well. ERCP is used as both diagnostic as well as therapeutic means. Once we diagnose the patient and assess the patient to severity, then the subsequent management also depends on the severity of the disease. If the patient is having a mild or grade 1 cholangitis, antibiotics and general supportive measures are to be started. And some patients, with a minority of the patients, would be just managed with antibiotic, but most of the patients would require biliary drainage. However, in cases of moderate or severe cases, these patients definitely require urgent or early intervention for biliary drainage, apart from the antibiotics as well as the general supportive treatments that need to be given for these patients. In terms of looking at the empiric antibiotic therapy, if you consider a patient to have a severe or grade 3 acute cholangitis, antibiotics should be initiated as soon as possible, ideally within 1 hour of diagnosis. And these should cover for both gram-negative as with a good coverage for E. coli and Klebsiella. And the antibiotic should also, should be ideally adjusted based on the local resistance pattern and biliary penetration as well. So choice, some literature suggests for mild cases, either ceftriaxone or ceftriaxone with metronidazole is sufficient, but others, if your patient is having moderate or severe, piperacillin, tazobactam, or carbapenem should be given. However, it should be considered that there may be higher incidence of ESPL or carbapenem resistance, especially in cases of nosocomial cases. And subsequently, these antibiotics should be adjusted based on culture and the clinical course of the patient, especially if the patient does not respond within 24 hours after starting the antibiotic. Then we should be having low threshold to escalation of therapy. So Tokyo guideline also comes up with the management bundle, which initially gives guidance on initial assessment, early risk stratification, and prompt antibiotic therapy. And early biliary drainage, especially in cases of grade 2 and 3. And if apart from the biliary drainage, hemodynamic as well as organ support are needed, and ICU admission is needed in mostly patients with organ support in cases of severe cholangitis. And it is especially important to monitor the patients for their response and adjustment of the management based on their clinical course. So looking at, apart from the antibiotics, and the most important thing for managing these patients is looking at the biliary drainage. So when do we drain and who should be drained? So usually the general recommendation is to regardless of the degree of severity of severity of the acute cholangitis, except in some cases of mild acute cholangitis, all patients with acute cholangitis usually needs biliary drainage on top of the antibiotics. And urgent drainage is needed for those who have moderate and severe acute cholangitis. The goal is actually to relieve the biliary obstruction and reduce sepsis and then reduce mortality. So looking at what is the technique that we can use in managing these patients for biliary drainage is actually the preferred modality is endoscopic transpapillary biliary drainage by means of ERCP with endoscopic sphincterotomy or with stone extraction and or stent insertion. This is less invasive because there is an internal drainage and then less discomfort, and usually accompanied with a shorter stay of the. However, sometimes these patients may fail. We may fail because of the various factors. In these cases, endoscopic ultrasound guided biliary drainage or PCT or percutaneous transhepatic cholangiography with drainage are alternative options. However, EUS guided biliary drainages should be considered in centers with expert who are experienced with this. And rarely, if everything else fails, surgery may be indicated in rarely, but however, it has a higher morbidity and reserved for cases only when we fail with all the other methods. Again, looking especially with patients, especially because these patients sometimes come with this severe coagulopathy, and some of the patients may present with already on antiplatelets. So the recommendation is in these cases to do ERCP first and avoid, if there is a coagulopathy or patient is on antiplatelet, avoid sphincterotomy or PTC. But in cases, if the patient is with a high thromboembolic risk, if the patient is on aspirin, we can continue the medication. But if the patient is supposedly on clopidogrel, if we have a choice, ideally the clopidogrel and those medications should be stopped 5 to 7 days prior to the procedure. If the patient has a coagulopathy or the patient is on antithrombotics, then endoscopic papillary balloon dilatation is safer and less bleeding risk compared with the sphincterotomy. In patients who has a surgically altered anatomy, balloon assisted ERCP is recommended over PTCD. However, again, balloon enteroscopy assisted ERCP is usually recommended in cases where if the endoscopists are both experienced in both enteroscopy as well as ERCP. If this fails, then EUS guided biliary drainage or PTC is recommended. Regarding the timing of biliary drainage, looking at the data from Japan and Taiwan, when they look at early versus late, based on the categorization based on the Tokyo guideline severity, they found that those who had early intervention had a low, the mortality rate was 30-day mortality was lower in grade 2. However, they did not find a difference in terms of patients in grade 1 and grade 2, probably because in severe cases, the intervention was too late, even though it is considered to be early. But later on, the French study looked at the patients with a severe acute cholangitis who required ICU admission. Those who had higher early by means of within 24 hours versus late, comparing these, looking at the 30-day and 1 year mortality and the length of hospital stay as well as ICU stay, other complications. The early intervention had a lower rate of mortality at 30 days and 1 year, as well as delayed shorter duration in ICU as well as hospital stay in. So this reflects that the need for urgent intervention in patients who are with acute cholangitis. So in summary, acute cholangitis is a condition that with a potentially high mortality and that requires prompt diagnosis and treatment. And the most validated guideline is Tokyo guideline 2018, and then which has a structured framework, and the diagnosis and the severity grading tools helps us guide regarding the diagnosis as well as therapy. And that it is important we give antibiotics and timely antibiotics, and that we do interventions urgently to improve the outcome in these patients. So I will talk about the second part of the presentation after this. This is acute cholecystitis. So acute cholecystitis, as we are all familiar, is an acute inflammatory disease of the gallbladder. Most of the time, this is caused by the obstruction from the gallstone, accounting for more than 90 to 95% of the people diagnosed with this condition. Gallbladder diseases affect, if you look at the literature from the US, around 220 million people are diagnosed with gallbladder diseases in the US. And annually, around 200,000 cases are diagnosed with acute cholecystitis. And around 10 to 15% of the adults have gallstones. However, 20% develop complications. And acute cholecystitis is the first presentation in around 10 to 15 patients with symptomatic cases. So usually looking at the etiology, as I mentioned earlier on, more than 90 to 95% of the cases are because of the calculus or gallstones obstructing the cystic duct. However, rarely, around 5 to 10% of the patients may have acute acalculous cholecystitis, even usually in acute critically ill patients, or those who are diabetic or HIV, or those who are on TPN, or those who had cardiovascular risk factors. So looking at the risk factors for development of cholecystitis, the most common risk factor, most important, is cholelithiasis. And patients with cholelithiasis are at a higher risk of developing disease. That means a female as well as elderly age has a higher risk of developing acute cholecystitis. Similarly, the cholelithiasis risk is also higher in Hispanic as well as Native American ethnicity. And the obesity and the rapid weight loss and pregnancy also predisposes people to develop cholelithiasis, and hence indirectly predisposes them to develop acute cholecystitis. Apart from that, diabetes and the medications like which we commonly use as ceftriaxone or octreotide also predisposes patients to have acute cholecystitis. Hemolytic anemia, like thalassemia or sickle disease, also predisposes patients to develop cholelithiasis. Hence, they also have a higher risk of developing cholecystitis. Looking at the pathophysiology, the important thing is the cystic duct obstruction by means of either stone obstructing, which subsequently leads to the stasis of the bile and then increases the inflammation, thereby increasing the intraluminal pressure, and which leads to the wall ischemia. Subsequently, there are secondary bacterial infection by means of E. coli or Klebsiella, and sometimes even if in the absence of stones, there might be acalculous cholecystitis, may also because of the bowel ischemia or bile stasis in the setting of critical illness or motility disorders may lead to the development of acalculous cholecystitis. This diagram actually describes the various stages of the acute cholecystitis, how it progresses. The early stage 1 is especially the complication rate and the development and the severity also depending on the degree and how long the obstruction is. So early stage is first 3 days, which is with increased intra-abdominal pressure, which leads to the inflammation. And subsequently, if it progresses, that leads to the hemorrhage, subsequently early necrosis. And then if in advanced cases, early necrosis, and sometimes rarely in up to 10% of cases of acute calculous cholecystitis lead to perforation. In cases of calculus cholecystitis, the necrosis and the perforation risk is slightly higher compared to the acute calculus cholecystitis. The clinical presentation is typically by means they present with a right upper quadrant pain, fever, and nausea. We usually see a positive Murphy's sign with a sensitivity is around 62%. And they may present with elevated white cell count. In patients who have acute severe cholecystitis, there might be a bit of clinically, you may notice the patient to be jaundiced, but the bilirubin is usually less than 3 milligram per deciliter. And again, Tokyo guideline is 2008 guideline is used for diagnosis, and then the diagnostic criteria we used for acute cholecystitis in Tokyo 2018 guideline criteria is again 3 parameters, looking at the local signs of inflammation, systemic signs of inflammation, and then imaging findings. When you look at these 3 parameters, if the patient is having one parameter item in all of these parameters, then it is considered to be definitive diagnosis. And if it is just one in item A and one item in B, then it is suspected acute cholecystitis. So various imaging modalities can be used. Again, as I mentioned, ultrasound is the first line with a sensitivity of 81%. CT is a good, but again, it has a disadvantage of around 20% of the patients, 20% of the gallstones are missed on CT. But however, it has a good sensitivity for looking for complications and then other complications as well. HEDA scan is by far considered to be the gold standard with highest sensitivity as well as specificity. And those cases suspected to have choledocholielithiasis, MRI, MRCP are the best. Looking at the severity grading for acute cholecystitis based on the Tokyo guideline, if the condition or acute cholecystitis is considered to be severe, if there is any one dysfunction, like any one organ dysfunction, like similar to the acute cholangitis, if there is any severe dysfunction like by means of cardiovascular dysfunction, neurological or respiratory or renal or hepatic dysfunction or hematological dysfunction, then the patient is considered to have a severe acute cholecystitis. However, the cholecystitis severity in moderate disease is different from the acute cholangitis. In this, if any one of the criteria, like by means of elevated white cell count, more than 18,000, or palpable tender mass in the right upper quadrant, or if the symptom duration is more than 72 hours, or if there are local complications like gangrenous cholecystitis or pericholecystic abscess or hepatic abscess or biliary peritonitis, then this is considered to be moderate acute cholangitis. In patients who does not fulfill the moderate or severe acute cholecystitis, then these patients are considered to have acute mild cholecystitis. In other words, those who have acute mild cholecystitis are good candidates, healthy individuals without any organ dysfunction, and they have mild inflammatory changes. These are ideal candidates for early cholecystectomy without any postoperative risk. If we look at more closely at the diagnostic tests that we discussed earlier on, again, ultrasound has a very good advantage with high around sensitivity of 81 to 83%, but which is also available almost all the centers. Our disadvantage is actually it has a operator dependence, and sometimes there might be a limitation for patients with a higher BMI. CT, on the other hand, can identify other complications as well. But the disadvantage is, again, as I mentioned, it has a disadvantage of missing 20% of gallstones. HEDA scan, as I mentioned earlier on, is by far the highest sensitivity and specificity, which looks at the radio uptake of technetium-based, looking at the gallbladder emptying. If the bile uptake after the injection of the technetium, and then subsequently morphine administration. So if there is a reduction of uptake in patients who has after the morphine is given, then this is considered to be positive. MRI, on the other hand, reserved for patients if you have suspicion of choledocholielithiasis. And looking at the treatment option for acute cholecystitis, in cases of uncomplicated calculus acute cholecystitis, the ideal treatment is combination of antibiotics and then laparoscopic cholecystectomy. Ideally, in patients, it should be within 1 to 3 days. The complications rates are rare. Ideally, it should be laparoscopic procedure, but sometimes in some patients, depending on the surgical, the may need to be converted to laparotomy. In cases of complicated calculus acute cholecystitis, by means if there's a abscess or perforation, then laparoscopic versus open cholecystectomy. And sometimes if the surgically you're not able to do laparoscopically, or if you're not able to remove do the full cholecystectomy, sometimes subtotal cholecystectomy may be needed. However, if which is associated with the complication of cystic duct leak and then postoperative abscess and the recurrent biliary events. In cases of complicated calculus acute cholecystitis, on top of the preoperative antibiotics, you should continue the antibiotics for 4 to 7 days after the surgery as well. But if there's no complication, then after the postoperatively, there's no need for a continuation of antibiotics. In cases of acute acalculous cholecystitis, there is a laparoscopic versus open cholecystectomy should be ideal, but sometimes this patient might be too sick, and then operative procedures may not be successful. So in such cases, percutaneous cholecystomy may be needed. Having said that, some studies looking at comparing the surgery versus cholecystostomy compared that the recurrence events were higher in patients who had cholecystostomy tube. So again, this is a summary of what I have just described. Early laparoscopic cholecystectomy for uncomplicated cases. Complication rates are fewer and the shorter hospital stay if it is done early on, and the cost is also low done early on. And in case of acute cholecystitis, uncomplicated cases, antibiotics is only limited to preoperative management only. And complicated cases and acalculous cases, as I mentioned earlier, sometimes we may need to go for percutaneous, but has a higher complication rates and compared to the surgery. Having said that, there are some special populations looking at elderly people and pregnancies and patients who have a surgical risk, especially those who have advanced cirrhosis and by means of child C or MELD score of more than 15, they have a highest postoperative risk. But generally, in patients who are older, also the overall 2-year mortality is lower if the surgery is considered early in this patient. And pregnancy is also considered to be generally in pregnancy also it is safe to consider surgery, because some studies looking at Americans in the US looking at the safety of the surgery in patients who present with cholecystitis, looked at the risk of fetal risk was lower in patients who had early, meaning those who had a surgical surgery within one day compared to the later, compared to the 7 days in terms of fetal risk. Again, as I mentioned, usually there are some complications, but which is low associated with cholecystectomy, like bile duct injury, which is very low, 0.4 to 0.6, and infections or bleeding risk is also low. But in cases where if the subtotal cholecystectomy is there, the risk of bile leak, abscess, and recurrence is higher. So in summary, acute cholecystitis is also common, and it is also potentially severe. Hence, it is important to diagnose early by means of clinical as well as imaging modalities. And early laparoscopic cholecystectomy is the standard of care, and special consideration should be given in patients who have advanced cirrhosis, but it is generally considered to be safe in elderly as well as pregnant patients. Thank you.
Okay, Muaz, thank you very much. That was quite a tour de force. Well done. I think you covered sort of the basic concepts very well. I think you've laid the groundwork very nicely for us to have a discussion around some points. Yeah. So as I say, I think there's very little that I would disagree with you on. I think you've done a good job. But there are maybe one or two practical points that we can maybe just highlight. So if you don't mind, what I'll do is I'll make a couple of comments, and then I think we can open the floor for questions. So you mentioned, so let's talk first about cholangitis. You did mention the possibility of sepsis, biliary sepsis being introduced into the lymphatic and venous systems. And I think that that is a particularly important point to make because there's a group of patients that can masquerade as cholangitis, or may start as cholangitis, and then develop portal vein thrombosis with superadded infection. And that is a group of patients that is exceptionally difficult to manage. They often present profoundly unwell, often they're often grade threes with organ dysfunction. They often end up in ICU, needing inotropic and ventilatory support. And it's really important that you actively look to exclude that diagnosis because the bottom line is if you don't add anticoagulation therapy to your antibiotics, these patients generally won't improve. They need both components. And quite often these patients end up taking quite some time before they start responding to your therapy. And you may have a situation where you've drained the biliary system, you've put the patient on antibiotics, and you can't figure out why the patient is not improving. So, in other words, so what I'm saying is just a word of caution. When you have a thrombosed portal vein branches, that can often appear as biliary dilatation, or to the untrained eye, that can look like biliary dilatation. And you send the patient and if cholangitis was the cause, then you will have biliary dilatation as well. And what will happen is you'll end up trying to secure biliary drainage, be it percutaneously or endoscopically. And again, as I said, the patient doesn't necessarily improve the way you would think they would. Okay, so beware portal vein thrombosis, especially with superadded infection, what we call portal pyophlebitis. Okay. The second point I wanted to make is, look, cholangitis can occur with any type of biliary obstruction. However, one should appreciate that more often it is in keeping with stone disease or in tandem with stone disease than with malignant disease. Okay. And so when you have a patient who presents with de novo cholangitis, I'm not saying that it excludes malignant disease, but you're far more likely to have stone disease. And direct your investigations towards that. Now, in tandem with that, I want to say, so just to summarize that point, it's uncommon. I think it's fair to say that it's uncommon for patients with malignant disease to prevent de novo with cholangitis. So if a patient is presented with cholangitis in an uninstrumented system, in other words, a virgin presentation, you're probably thinking more stone disease. Now, you made the point a number of times, and I'm really glad you did. And that point is that a CT scan is not a good investigation for stone disease. Okay. In both cholecystitis and cholangitis, you mentioned that ultrasound, although it might not be the most sensitive modality, it is the modality of choice. Okay. And that is the investigation that you should be asking for first in most patients, unless you have a specific reason to go for something else, be it CT or MRCP. And as I said, the main reason for that is that CT will only pick up 80% of gallstones. So just the way to remember that is What is a CT scan? A CT scan is fancy X-rays. Okay, you lie in a tunnel that is basically an X-ray machine. That machine fires hundreds of X-rays at you, and a computer takes those images and puts it into a format that we can understand. Hence why it's called computed tomography. Tomography means X-rays. Okay. So gallstones are predominantly, well, the majority of gallstones are cholesterol stones, and cholesterol doesn't show up on an X-ray. So only 10 to 20% of gallstones will be visible on an X-ray or on a CT scan. Okay. 80 to 90% of gallstones will not be visible on a CT scan. All right. And the easy way to remember that is you contrast that with kidney stones. 80 to 90% of kidney stones are visible on a CT scan. All right. So it's 10 to 20% of gallstones and 80 to 90% of kidney stones are visible on a CT scan. So a CT scan is really not the best investigation when a patient presents with biliary obstruction, even in the setting of sepsis. Okay, what you still want to do is get an ultrasound first. And what you want to know from that ultrasound is, are there stones or not? And what is the level of obstruction? If you think about it simply, in any patient with biliary obstruction, the first things that you want to know is where's the blockage and what's causing it. Biliary obstruction is a blocked pipe. When you're faced with a blocked pipe, you want to know where's the blockage and what's causing it. And an ultrasound will tell you that. So the first thing you want to know, now, if you think about what the vast majority of biliary obstruction that you will see in your practice, unless you become a specialist HBB surgeon, the vast majority of biliary obstruction that you will see will either be stones, or because they are the commonest, by far, the commonest cause of benign biliary obstruction, and malignant biliary obstruction, but that'll cover everything else. Okay. So yes, as a gastroenterologist, you do need to be familiar with the rarer cause of biliary obstruction, like PSC, like IgG4 disease, etc., etc. But it's very rare that those patients are going to present to you with profound biliary obstruction, and in particular cholangitis. So for your intents and purposes, and certainly for this discussion, when you think about the causes of biliary obstruction that are likely to cause cholangitis, it's either stones or cancers, stones being more common. So what you want from your ultrasound, you want to know what's the level of obstruction? Is there intra and extrahepatic biliary dilatation, or is there only intrahepatic biliary dilatation, in which case your obstruction is hilar, and that represents a very different clinical problem than when the obstruction is lower. Or is there no biliary obstruction at all, in which case you need to be rethinking your whole strategy, your whole diagnostic strategy. Okay. If there are no stones on the ultrasound, now you're worried about a non-benign pathology. And now you're going to be thinking about cross-sectional imaging, and probably a CT scan is reasonable to do as a next step, looking for a mass or looking for the point of obstruction. But probably an MRI, MRCP, if you have all modalities available to you, that might be even better. Okay. And certainly if the obstruction is hilar, then you want an MRCP. Okay. All right. The absolute key thing about cholangitis is you need to make a decision quickly about whether or not your patient needs biliary drainage. All right. Patients who are cholangitic can die within the space of hours. All right. So, yes, the grade ones, the mild patients, so no organ dysfunction and none of the warning things we were talking about, like a higher white cell count or lower white cell count, increased platelet count, etc. If your patient simply has biliary obstruction or raised LFTs and say a white cell count of 12 and a not particularly impressive temperature, okay, it's fine to put that patient on antibiotics and maybe see what direction they go. They may settle, or you can defer your further investigations to the next day. But if you have a patient who's grade 2 or grade 3, that patient needs something done Otherwise, you may find a dead patient in the morning. Okay. So please, biliary drainage is absolutely key in the grade twos and threes. And you need to make, and in making your quick decision about whether drainage is necessary or not, you need to apply your mind to what imaging you want. So as I mentioned a moment ago, I think ultrasound in an, shall we call it an undifferentiated patient, so a patient where um, the likely diagnosis is not immediately apparent, you probably want to start with an ultrasound. But having said that, um, if you have a patient who has a history of biliary colic, it fits the demographic completely, um, then again, I think you're probably going to start with ultrasound, but an MRCP may be, if that's easily available to you, that can be a good option. On the other hand, if you've got an 80-year-old who's lost weight, a newly diagnosed diabetic, um, has no risk factors or suggestion of stone disease, and you really think that this may be malignancy, well, then maybe it's not unreasonable to go for a CT scan, or at least anticipate that that's what you might need. But I think, as I said, as a general rule, ultrasound is where you start, and based on that, you may decide on what else you want next. But in a fit patient where you suspect stone disease, you're probably going to go for an MRCP as a cross-sectional modality. In a patient that fits the bill for malignancy, then you're probably going to go with a CT scan. Um, the trend of your liver function tests. So that can be really important. So it's often useful to know what is happening in terms of a trend. Are the bilirubins going up or are they settling? A significant proportion of patients are going to have small stone disease and the stones may pass. Alternatively, you need to keep in mind that certain patients can have stones that can move up and down within their duct and have fluctuating LFTs. So just be aware of that. Um, if the trend is continuously down and the patient is settling on antibiotics, then you may not need to do anything further, and it may be worthwhile to image the duct with an MRCP to confirm that the stone has passed. Um, on the other hand, if the LFTs go down and then go up again and then go down again, then you may be faced with a stone that's moving up and down in the duct. And again, you may want to image that duct non-invasively with an MRCP. So bear in mind, an ERCP is not a diagnostic investigation. Okay. If you're going to do an ERCP, it means you should be doing it because you strongly anticipate performing a therapeutic maneuver or procedure at the time of what you're going to do. If all you want is an image of the biliary system, then you should be getting an MRCP. Okay. An ERCP is not a diagnostic modality, it is a therapeutic modality. And the reason why we emphasize this so much is because it carries risk. All right. An ERCP always carries the risk of inducing pancreatitis. And if you do that in an already sick patient, then you run the risk of making things much worse. So, a quick word on the particularly sick patients with cholangitis in whom you're going to do an ERCP. Do not spend time, you know, not spend a prolonged period of time trying to extract a difficult stone. Okay. If you make a sphincterotomy cut and you can see that there are small stones and they come out easily enough, okay, that's fine. But you don't want to be you don't want to perform a prolonged procedure in a patient who's critically unwell. Um, by placing a significant physiological challenge on them, which is your procedure. Okay. You want an abbreviated procedure that achieves your objective, and your objective is biliary decompression, biliary drainage. So if you've got a sick patient, definitely the grade twos and threes, and you're going to attempt an ERCP, get in, get your biliary access, put in a stent, get out. Okay. And come back to fight another day when the patient is much better. Do not spend prolonged periods injecting contrast and trying to get stones, difficult to extract stones out of a patient who's sick. Okay. bearing in mind that if you inject contrast into a system under pressure, you may force the bacteria into the venous or lymphatic systems. And I've been called to patients who've crashed on the table um, dramatically with hypertension and even being peri-arrest because of injudicious cholangiography being performed in a patient who's got cholangitis. Okay. Remember that system is under pressure already. The moment you inject something, the moment you inject contrast, you're increasing that pressure and you will force bacteria into the bloodstream. Those patients, as I say, can react profoundly to that. So in the sick, get in, put in a stent, get out. Okay, I think I'm going to stop there for a moment and just hear if there are questions on cholangitis specifically before we discuss one or two issues around cholecystitis. Okay, I think we have a question in the chat room. Okay, the question for Muaz. Given ceftriaxone's association with biliary sludge and pseudolithiasis, should it be avoided in the treatment of cholangitis, especially when alternative antibiotics are available? What do you think, Muaz?
I think, I mean, even though it is risk is there, but usually it is associated with prolonged duration and higher doses. So with the current doses, the risk is low, and then once the medication is continued, the risk there is it's a reversible. It's not like a higher thing. So I think it's relatively safe. But having said that, we should be aiming because it's only considered in a mild cases. So I would, if it's a severe cases or moderate cases, then I would go something apart from the ceftriaxone, higher antibiotics.
Yeah, well, I absolutely agree with you. The issues, those issues around those biliary complications of ceftriaxone relate to more prolonged administration. We're talking about the acute setting here. So I think that's less of a concern. But as you've said, I think you want to um, remember your initial. Okay, let me backtrack for a second. An absolute key issue is has your patient's biliary system been instrumented before or not? Because the organisms that you're going to be dealing with, if the patient has had biliary instrumentation before, are going to be the bugs that are related to that unit. And they are going to be more resistant and more difficult to treat. And you should have an idea of what bacteria you're seeing in your unit. Currently, in terms of the cultures that we have, um, we would probably start with pip-taz and amikacin if the renal function would allow, and then we would look to early escalation to a carbapenem like ertapenem or probably more like meropenem if there was failed response. That is for nosocomial organisms in our hospital. If you're talking about the patient who's come in who's, let's call it biliary naive, in other words, they've had no instrumentation, then you're talking about community acquired bacteria. And those organisms are going to be far more sensitive. And, if you, depending on the patient that you're treating, I think if we were dealing with a severe infection, I think we'd probably go with Pip-Taz as a start. But as a mild, if it was a milder attack, we probably would even be happy to start with triple antibiotics or even augmentin for a community-acquired infection. Okay. Um, the other question that's here is how long should the anticoagulation be in the case of a portal vein thrombosis? So surprisingly, there aren't clear guidelines on this, but we would look at 6 months. Um, and keeping in mind that you'd start with therapeutic Clexane and then transition to an oral equivalent. I think in many centers, warfarin is only what would be available to you, but I think rivaroxaban is a really nice option, especially in these patients because in case they may need further biliary interventions in future, and you don't want to be dealing with warfarin-related issues then. So yeah, but in terms of if you have diagnosed a portal vein thrombosis in a patient and you are and it's an acute thrombosis such that you're going to actively treat it, then you're probably going to be looking at least 6 months. Okay. Any further questions? I'm not sure if anybody. The other options are to raise your hand, and we can come to you. All right. Okay. If not, just two or three comments on cholecystitis. Again, was well done. I think you gave us a really good approach. I want to caution people around the diagnosis of acalculous cholecystitis. I recently saw this diagnosed in a patient who presented as an outpatient, who was quite unwell, but a source of sepsis could not be found, and so it was attributed to the gallbladder and a perc drain put into the gallbladder. Almost certainly, probably something else was on the go. This is an uncommon diagnosis, and you mentioned very clearly the situations in which we encounter it. It's usually critically ill patients, usually patients on TPN. Outside of those situations, I think you must be very cautious about making that diagnosis, being sure that you're not missing an alternative source of sepsis. Definitely, you should be seeing some changes in the gallbladder with distension, thickened wall, and exclusion of any other pathology. You mentioned the HIDA scan, and I think I should probably just be aware that I think that this is quite institution specific. Certainly, it can be a sensitive modality. Certainly, it is good at determining the ability of the gallbladder to empty empty itself of its contents. But I must say we've never used it in at UCT at any rate, and I'm not sure how widely available it is. So it may be a good modality, but um, I think what's more important is that candidates, especially coming up to your exams, you should know what is the modality that is used in your institution. Okay, and certainly we would be more guided by cross-sectional imaging, like ultrasound or a CT scan, if we specifically want to interrogate the gallbladder in that way. But almost always, if you're wanting to evaluate the gallbladder, an ultrasound accompanied by the clinical and biochemical results would be what would guide us. You mentioned percutaneous drainage of the gallbladder, and I think, and you correctly mentioned the situations when we would use it. In particular, so it would be our modality of choice for an acalculous cholecystitis. It would be our modality of choice in a patient who is too unwell to go to surgery. Okay. Um, and obviously is not responding to conservative treatment with antibiotics. Um, so the commonest that is the commonest scenario. So usually you have an elderly patient, 82 years old, diabetic, hypertensive, touch of cardiac failure. She spends her day mostly on the chair watching TV. She's got a BMI of 58. The absolute sort of nightmare patient. Okay, who you really think who they are unwell now, obviously with sepsis. They might get better once you put the drain in and treat the sepsis, and they might get to a point where they're well enough to have surgery, but certainly they're not in that state as they lie in front of you at the present moment. Now, that's the kind of person who needs drainage of their gallbladder. So as I said, these are patients not responding to antibiotics, and you don't have any other sort of treatment modality. So that's the kind of patient that you would put a perc drain into the gallbladder. You should be aware that as a competitor option, there is now EUS gallbladder drainage. if that is available in your institution. Okay. It is fairly widely available around South Africa where EUS is available. We've done probably 10 to 20 cases, not as many as some of our northern colleagues. But it does represent an attractive option in that it's relatively simple to do once you know how to do it. Okay, you need to be an experienced endosonographer, and you need to be well trained in the use of the accessories that go with this procedure. We've seen multiple complications relating to this. And so, just really a word of caution. It is an attractive modality. It means the patient is drained internally. You can go and subsequently remove all of the gallstones from the gallbladder and treat these patients fully. Um, but it really needs to be in expert centers that are very familiar with this. Putting a perc drain in the gallbladder is often quite a benign procedure. It can be done by most interventional radiologists or even radiologists with a bit of interventional experience, and it often resolves the acute problem for you. A word, if you have put a cholecystostomy, performed a cholecystostomy, in other words, you have placed a percutaneous drain into the gallbladder, be aware that obviously now you're draining the gallbladder. The stone that's impacted the cystic duct may well disimpact, and you may end up draining the gallbladder, draining all the bile. And these patients can end up losing a lot of fluid and electrolytes if you are draining their gallbladder and it's no longer obstructed. You should leave, your radiologist should always try and go through, they shouldn't try and go into the peritoneum and into the gallbladder. They must go through a cuff of liver. Otherwise, you run the risk of leakage of bile into your peritoneal space. Once the perc drain is in the gallbladder is emptied and your patient is done better, you need to ascertain whether you can take the drain out or not. You should never remove the drain before 2 weeks because you need a tract to have formed that from where the drain goes into the gallbladder through the liver, through the peritoneal space at the top, and up out through the skin. You need a confirmed tract. If you don't have a tract and you take that drain out, the patient will leak bile along the tract, and it may exit into the peritoneal space. Before you remove the perc drain, you must confirm that the cystic duct has become patent. Otherwise, the patient is just going to recur. And you should do that by doing a cholecystogram. It's very simple. You inject some contrast down the catheter, down the percutaneous catheter, and you wait to see what happens. If contrast enters the biliary system and exits into the duodenum, you know that the cystic duct is patent. You can pull the drain, and the tract will seal up, and you basically will return to position one or the starting point. The last thing I wanted to mention is cholecystectomy in pregnancy. The traditional teaching has always been that you should try and, if you're going to perform it, you should perform it in the second trimester. I am aware that there's literature that's debating that, or that has come forth to suggest that you could do it in any trimester. I think in the exam situation, I think that's just what you would say. I'm not certain that things are absolutely conclusive on that topic. So all I would say is that historically, cholecystectomy was performed in the second trimester. However, there is now literature coming out to suggest that it may be safe in all trimesters. But perhaps you would want to wait till more evidence is available before we could make a definite sort of comment on that. Okay, any questions about cholecystitis? Muaz, I think I put everyone to sleep. All right. So a last offer. So I see we are already a little bit over time. So a last offer in terms of any last questions? Let's just see something. Nope, I'm not seeing anything further in the chat. I'm not seeing any new hands up. So, okay, Muaz, I think we can probably call the meeting to a close. Once again, Muaz, thank you so much. I think you did a really great job. And sorry, I'm just trying to get up my email here. I think you did a really great job. So thanks again. I know you put a lot of work into it, and I thought it was really great. Um, okay, so thank you again. Thanks also to Echo from the University of New Mexico and Echo India for this support. These recordings are available on the Gastro Foundation website, should you want to go through them again. And so lastly, thanks again to the Gastro Foundation. The next session will be in 2 weeks' time, Monday the 25th of August. We're talking about liver abscesses and cystic liver diseases. The presenters will be Lillian Musioka, facilitated by Christo Kloppers. All right. So with that, good evening, everybody, and thanks. A last thanks again to Muaz. A great job done.
Thank you so much.